First of all, I want to thank Professor Salah and Dr. Ahmed for the invitation. It's really a pleasure to be part of this. MashaAllah, every year is better than the year before. I'm presenting our experience in King Faisal for the complex renal artery aneurysm repair, no disclosure. The first case is an 18-year-old kid with a history of persistent hypertension, maximized on 3 antihypertensive medications. He was referred from Taif with a left renal artery aneurysm discovered during abdominal ultrasound as a workup for the hypertension. The CT scan showed about 2.7, 2.8 centimeter on the left distal renal artery, as you see there, just at the trifurcation or the bifurcation of the subsegmental renal arteries on the left side. After this and discussing with the family, we actually worked him up for a nuclear scan to see the perfusion of the kidney, and it shows equally distributed between the both sides, about 51 on the contralateral side and 48.8 on the left kidney, where the aneurysm is. So at this stage, we had a long discussion with the family, given his age and uncontrolled hypertension, to either perform a nephrectomy or reconstruction, which will include and requires more extensive ex vivo and auto transplant. So they did not want to give up the kidney, and we proceeded with the intervention. The second case is an older lady, 52-year-old, older than the first patient. However, she's still premenopausal, and she also has presented with persistent hypertension on 3 maximum agents. Referred as an abdominal ultrasound showed right renal artery this time during ultrasound for abdominal pain. And the CT scan showed almost 3 centimeter, 2.9, and maximum diameter of the right renal artery. Again, distal at the bifurcation or the trifurcation of the renal artery. Unfortunately, her situation was more of 2 symptoms, abdominal pain and the uncontrolled hypertension. In addition to that, she also has an equal distribution of her renal function in the nuclear scan as well. Again, a long discussion with the same patient take place, and she wants to preserve the kidney, and she refused nephrectomy. And as you all are familiar with, the indication of the renal artery aneurysm repair is symptomatology and size, as well as the persistent hypertension, if depends on any size. So we attacked both cases. We have a left kidney case and a right kidney case. Both started with the laparoscopy approach to do the nephrectomy part. In the laparoscopy part, you need an umbilical port in the umbilicus for the scope, and 2 other working. Is there a laser here? 2 working ports placed at the ipsilateral side in the upper and lower quadrant, and the last working port, it's on the contralateral side and the lower side, where you can convert and retrieve the kidney. After we pulled the kidney and did the nephrectomy, in the first case, we used the custodial solution, which they used in the transplant reservation solution, basically heparinized cold saline. And as you can see here, this is the ureter of the right kidney. The vein, and that's the challenge always when you do the ex vivo reconstruction, is always the vein is very adherent to those aneurysm sac. So you got to take your time and dissecting off the artery until you figure out how many subsegmental arteries are coming off that. So we finally we reached down to find 3 aneurysm sacs between the first order and the second order branches of the renal artery. After we infused to identify those branches, as you can see 4 subsegmental branches coming into the kidney down there, but there is also a 5th one in the back. We dissected each individually, and obviously this is going to take more than 30 minutes, so this is why we're doing it ex vivo with autotransplant. After that, we did, that's the renal vein there, we did a pentolon reanastomosis side by side, and those 2 subsegmental, and the other one we used it as direct reimplantation, and the other 2 also we did side-by-side pentolon and used the extra healthy side of the distal or the proximal, renal artery to reimplant it to give us more length when we reimplanted. That's basically what we did. So then we reimplanted it in as we do in the transplant side or patients at the external iliac artery. And you want to make sure that when you do this step is this is not a straight transplant patient where you have a single artery and you configure the position of the kidney easily. You got to find a way or find the position of the kidney that it's not going to kink your vein or your renal artery later on. And that's basically what we ended up doing into the reimplantation. The second case is almost similar. However, the vein was very adherent this time to the artery, so we did almost reconstruction using both pentolon side by side and end to end to create more length of those wanted reimplantation of the vessel. Both cases went, alhamdulillah, very well. Post-op, the patient had a good urine output. No AKI, no kidney function deterioration. The duplex in day 2 showed well perfused kidney in each side, as well as the first case, which was the 16-year-old kid. He was actually off the antihypertension medication 2 months later, and the second lady was down to a single very low dose. That was about a year ago, and I saw her a couple of months ago, and she's, alhamdulillah, completely off the medication. So in summary, renal artery aneurysm is not very common. It's about 0.1%, and the management depends on the size and the symptomatology. Intervention options varies, and decision has to be based on location, morphology, and symptomatology of the aneurysm. In case of the complex aneurysm, which is multi-branches, where you suspect to repair it, the repair takes more than 30 minutes ischemic time. Your option will be either nephrectomy, which is easier, or resection with autotransplant with ex vivo repair. Thank you so much, and this is King Faisal Specialist Hospital in Jeddah. Hopefully next year we'll do a live case from there, inshallah.